Good day, everyone. Today I'll be speaking to you about anesthesia for shoulder surgery. Most of information I'll be sharing with you in this presentation is based on my training at Anaesthesia Hospital in Cape Town and my clinical exposure at the Toronto Western Hospital in Toronto. So the outline of this talk is we will start with the anatomy, we'll look at the indications for surgery, anesthetic approach, complications, and the conclusion. So just a quick look at the shoulder anatomy, because as anesthetists, we need to have a general understanding of the anatomy because it helps us to decide on the type of blocks that we will administer to treat pain in the perioperative and postoperative period following shoulder surgery. So the shoulder consists of the clavicle, the scapula, and the humerus. The joints that are involved include the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint, and then the scapulothoracic joint is noted to be more of a pseudo joint. Then we looking at the shoulder anatomy. The muscles of interest are the rotator cuff muscles. And if you're in medical school, they would have taught you about the mnemonic SITS, which stands for the supraspinatus, infraspinatus, teres minor, and subscapularis. The rotator cuff muscles are very important because they're involved in movements related to abduction, internal and external rotation of the shoulder. The other muscles of interest include the deltoid muscles, the biceps brachii, and then the accessory muscles that are involved in stabilization and movement of the shoulder. These include the trapezius, serratus anterior, and latissimus dorsi. So when it comes to the innervation of the shoulder, the brachial plexus is the one that mainly innervates the shoulder. The nerves that are of major interest to us are the axillary and suprascapular nerve. The suprascapular nerve plays a big role in terms of cutaneous innervation of the shoulder, and it contributes about 70% towards that. So that's a nerve that one needs to make sure is blocked when you're administering a regional anesthetic for shoulder surgery. Patients who are coming in for shoulder surgery might be coming in for things like a shoulder arthroplasty, shoulder arthroscopy with or without surgical intervention, a lateral ray rotator cuff repair, or a slap repair with or without biceps tenodesis. Obviously, these are not the only procedures, but these are the procedures that I commonly have noted in my anesthetic practice. So the patients that often present for shoulder surgery could be the young athletic patient who has sustained an injury to the shoulder during a practice session or maybe when they're out competing. And the other spectrum is patients who are elderly who have suffered either shoulder injuries or they have chronic shoulder pain due to wear and tear. The patients who are much older are the ones that we're mainly concerned about because they present with multiple comorbidities, and sometimes they may have things like hypertension, history of coronary artery disease. They might also have things like rheumatoid arthritis, and which might be involving the cervical spine. So one needs to exercise care when performing airway manipulation or laryngoscopy and positioning these patients in the perioperative setting. So what anesthetic approach can one use? Generally, most anesthetists go for a pre-op block and then a general anesthetic thereafter with an endotracheal tube. There is a mention in literature of some people using laryngeal mask airways, but in my practice, I tend to use endotracheal tubes simply because a laryngeal mask airway is not a definitive airway, and sometimes when the surgeons need to manipulate the shoulder, it can happen that the LMA can be dislodged, and then that may require the anesthetist to attend to the airway and disrupt the surgery and actually affect the flow of the work in the operating room. So we prefer to intubate the patient, because then that also gives you a sense of peace of mind. The other thing as well, these patients may require muscle relaxation because the surgeons often require that the patients be adequately relaxed so that they can be able to access the tissues around the shoulder with ease. So then an endotracheal tube is more attractive, and also the duration of surgery. So if a patient's going to have shoulder arthroplasty, most of those procedures that I've witnessed tend to take about 2.5 to 3 hours. It's better just to have an endotracheal tube in situ. Sometimes patients can have a pre-op block followed by conscious sedation. However, it is important to kind of select your patients, because not every patient will agree to having a conscious sedation, and not every patient is a candidate for conscious sedation. So if, for example, if the surgery is prolonged, maybe it's better to go for a general anesthetic as opposed to conscious sedation. If a patient is very anxious and there are issues around operation, a general anesthetic will be the better choice. Another option will be going for general anesthetic only, and I have had patients who have refused to have a block for their procedure. They would prefer to have IV analgesics and oral analgesics in the post-operative setting. However, because of the nature of the surgery, some of them end up requiring huge amounts of opioids in order to cope with their post-op pain. Another option that can also be instituted is to administer general anesthetic and then followed by a rescue block in the post-op period. What I've found with this technique is such that when the patients wake up, they are in excruciating pain, and even when the rescue block is administered, the pain relief is not instant. It takes a little bit of a while for it to eventually diminish. Generally, when treating pain, it's always good to treat pain early, because it's very difficult to treat pain when it is flared up. It's like you are literally chasing a running train. All right, so regional anesthetic techniques that one can institute for shoulder surgery: interscalene block and the superior trunk block. So the interscalene block is widely used by many anesthetists in practice. It has been used for many years, firstly using the landmark technique. Nowadays, people tend to use ultrasound. The superior trunk block is new, and it is now becoming more fashionable simply because it has less complications as compared to the interscalene block, and is also easy to perform. Another block that is performed is the one that involves the axillary and the suprascapular nerves. This one can be used if interscalene and superior trunk blocks are difficult to perform, or there are issues in performing those two. But the best analgesic cover is when one institutes either the interscalene or the superior trunk. Then on your screen, you can also see the block that I've put in parentheses, that the superficial cervical plexus block, which we mainly use as an additional block, because the interscalene and the superior trunk block do not cover the shoulder cape. So the superficial cervical plexus block will cover that. The downside of the superficial cervical plexus block is that it will tend to cause numbing of the jaw. So an alternative will be the supraclavicular nerve block, which you administer by infiltrating local superficially above the middle scalene muscle. So just revisiting the brachial plexus. So the brachial plexus is formed by the roots from C5 to T1. These then combine to form the trunks, and of interest is the superior trunk. And then later they divide into the different divisions, and you get the cords and the branches. So our main focus is in the area of the roots and the trunks, because this is where we want our local to have its effect, and in particular C5 and C6. So looking at this diagram, which I have so conveniently been obtained through Anaesthesia, on the left we have the cartoon which shows us the area of interest where we have C5 and C6 roots, and then this is the so-called robot or traffic light sign, and then we have the anterior scalene muscle and the middle scalene muscle. So the plexus is sandwiched between these two, and this is the area of interest where we are going to deposit our local anesthetic. So when he described this technique, it was basically based on the anatomical landmarks. However, anesthesia has improved, and we tend to do these blocks under ultrasound. And on the right, you can see an ultrasound image of the artist's impression on the left. So here it is, C5 and C6, the so-called traffic light sign, C5, C6, C7, and it's sandwiched between the anterior and middle scalene muscles. And this is SCM, is the sternocleidoid muscle. It's also important to note how superficial these structures are. So when you place the ultrasound probe on the patient, it's important to determine the depth that which your needle needs to traverse to get to the area of interest. Unfortunately, on this image, on this sonar image, you can't see the depth, but I feel it's very important to do that because that will help you reduce the chances of injury. It's also discouraged when you are performing this block to enter from a place that is distant from the area of interest, because there's a risk of then injuring nerves like the long thoracic nerve, which may end up resulting in a winged scapula. So this is how you do it. Obviously, you clean the patient's neck, drape appropriately, apply some ultrasound gel, cover up your ultrasound probe, and then you're going to use a block needle. Ideally for this block will be a 50mm needle because the structures are quite superficial. Then when you get your sonar image and advance your needle, your area of interest, you want to deposit the local in this region, and we see the needle entering through the skin and subcutaneous tissue, eventually landing in the area of interest. And the way this operator has performed this block is excellent in that they have avoided any deep structures. They've passed above the middle scalene muscle and gone straight for the area of interest. The next step will be to, once you have felt a pop and you're sure that the needle has entered in the area of interest, is to then inject some local anesthetic. Obviously, we always use the method of aspirating to make sure you're sure that there is no blood, and also to check your injection pressure so that you are sure that you are not injecting intraneurally and causing injury. An important thing to note is that we do perform these blocks in awake patients. Why do we do that? It's because then the patient can alert us if they're feeling any pain or paresthesia. And in my experience, it's advisable to do this block using a nerve stimulator as well, because it helps to show you if you are getting too close to your roots. And normally when that happens, the patient starts feeling a lot of discomfort, and you can actually see the motor response in the limb. And so that helps you. And when you get an exaggerated motor response, you can easily just pull back and then introduce more local and avoid getting too close to the roots. Another important thing, I've often noted that some people will then introduce local on both sides. There is no need to do that because you just increase the chances of injury to the roots. I've also seen people trying to advance the needle between the roots so that they inject local above and below C5, which I actually feel that that can actually cause more harm to the patient. So there is absolutely no need to try and push the needle in between these two, and there's no need to actually try and get the needle above and below. It definitely, the local will definitely be able to cover the roots very well, even if you inject it just in one little pocket. The other important thing to note is that when we look at ultrasound images, we are looking at two-dimensional images. So just because you've just injected local on this side does not mean that the local doesn't end up spreading onto the other side or posteriorly. So that's an important thing to note, and that will help you change your practice if you've been doing that, so that you just reduce the chances of having complications in your patient group. So there have been studies that have shown that if you're not careful with interscaling blocks, patients can actually have residual symptoms of numbness and tingling even up to 6 months. So you have to be cautious when you are performing this block. So one can use a single shot technique, which means you're just going to inject it once off, or if you are capable and there is an indication to put in a block catheter, one can insert a block catheter and continue to infuse local anesthetic so that the patient continues to benefit from the block even post-surgery. As I mentioned, we're going to use a 50mm block needle because the structures are superficial. I mentioned that using a nerve stimulator is helpful, and it will show you if you are close to the nerve or not, and it helps you to kind of have some safe room in order to administer your local without causing possible nerve injury. Obviously, not everything is fail-safe, but it's a general guide. I know this is controversial. I have spoken to some experts who have studied the complications of nerve injuries following blocks. Some of them do not feel that there isn't compelling evidence to combine the use of nerve stimulation with blocks, but the information that I'm presenting to you is kind of anecdotal. It's from my own experience. It just helps me to make the whole patient experience safer and more comfortable for the patient. In terms of analgesia, so you have to decide, are you going to do an analgesic block, or are you going to do a surgical block? Analgesic block, lower concentration, 0.25 plain bupivacaine or ropivacaine, and a surgical block, 0.5% plain bup or ropi. So actually using an analgesic block is better, less is more, in that you reduce the chances of local anesthetic toxicity by using a lower dose. And if the patient is going to have a general anesthetic, there is actually no need to administer a surgical block. So the volume you're going to use is in 7 and 15 mils. From my experience, I found that if you use large volumes of local for the interscaling block, you increase the chances of causing phrenic nerve palsy, Horner syndrome, and issues and hoarseness of the voice due to involvement of the recurrent laryngeal nerve. Adjuvants you can add to your mix adrenaline, otherwise known as epinephrine, at 2.5 micrograms per mil. That will reduce the risk of local anesthetic toxicity, and it will also prolong your block. You can also add dexamethasone, 4 milligrams, even up to 8 milligrams to your mix, to also prolong the block. Just by the way as well, dexamethasone can also be given IV. So if you've not given it in your block mixture, you can still give it IV. Evidence shows that it is still beneficial when given IV. And it can also help to reduce the pain. In terms of the coverage of the interscaling brachial plexus block, what I want you to appreciate in this picture, which I got from Anzo, is that the interscaling block tends to cover the lateral aspect of the upper limb. It doesn't cover the medial aspect, and it also doesn't cover the shoulder cape. So then there's a need for us to cover the shoulder cape, and that's why we talked about either doing the superficial cervical plexus block or doing the supraclavicular nerve block. Remember, I don't want to confuse you. So there is a supraclavicular brachial plexus block, which you perform below the clavicle. But when we're talking about the supraclavicular nerves, these are the nerves that are found above the clavicle, and where we want to inject the local to cover those nerves is above the medial scalene muscle and just subcutaneous, like almost superficial. And that's where you will be able to anesthetize those nerves so that cover the shoulder cape, and so that you have good cutaneous cover so that the patient does not have pain. What I also didn't mention is that for arthroscopic surgeries, what I have noted, because the surgeons use a lot of fluid when for irrigation, sometimes the fluid might track to the anterior chest, and you can see when you do the interscalene block, it's not going to cover the anterior part of the chest. So patients may experience some pain when they wake up. So they won't have pain in the actual shoulder, but they might feel anterior chest pain. It varies from patient to patient, and normally when this patient come in for surgery, I often warn them about that the block might not cover the anterior part of the chest, so we might need to supplement their pain medications with some IV medication. If you want cover in that area, you might need to do an additional block that covers the chest wall, but often most people don't. They just stick to doing the interscalene block. And then when the patient wakes up, they assess the condition of the patient, and if there's any need, they may supplement the block with IV analgesia. So the common complications we get when the interscalene block is phrenic nerve palsy, and this has been documented to occur more than 70% of patients. That is significant, especially when you use high volumes of local anesthetic. Horner syndrome, I've seen that is when high volumes of local are used for the interscalene block. And I've also noted patients having a hoarse voice due to involvement of the recurrent laryngeal nerve. Complications that tend to be rare. So the first three complications are not instant. They're not really life-threatening per se. But the others can potentially be, like if a patient has seizures, patient has a total spinal due to inadvertent intrathecal injection of local anesthetic or local anesthetic systemic toxicity. That can potentially be fatal. And because one is injecting local in the neck area, we know that the neck is extremely vascular. If a patient is on anticoagulants, there is a risk that a hematoma might form. So this is a patient who had Horner syndrome, and with Horner syndrome, typically they get anhidrosis, they get ptosis and meiosis. So this is what this patient presented with. Contraindications of the interscalene block is patient refusal. So if the patient refuses to have the block, you cannot force them to have it, even despite giving all the information of how the block might help them reduce their post-op pain and expedite their recovery. If the patient refuses to have the block, you cannot force them to have the block. However, I have noted that when some of these patients, when they wake up and they're in excruciating pain, they may potentially change their mind, and that's perfectly fine. Then you can administer the block in the post-operative setting. If a patient is allergic to local anesthetic, then you mustn't give the block. If there's contralateral phrenic nerve palsy, then you should not administer the block, because then the patient won't be able to breathe properly. If there's recurrent laryngeal nerve block, contralateral recurrent laryngeal nerve block, then you shouldn't. Or there's a recurrent laryngeal nerve injury, then you shouldn't either. So contralateral lung disease, so if a patient has had a pneumonectomy on the left side and you want to do an interscalene on the right, that would be a contraindication, because maybe the only lung they're relying on is the one on the right, and then if you perform an interscalene block, they're going to get diaphragmatic paralysis, or the diaphragm is not going to function as well. Then that's going to be a problem. They won't be able to breathe well. Or if a patient has got a contralateral lung disease like pulmonary fibrosis, they've got interstitial lung disease, they've got a pneumonia, or they've got a pleural effusion, or they've got a pneumothorax, then you should not be performing the interscalene block on that other side. So a block that's kind of getting more popular, more fashionable, is a superior trunk block, simply because it's performed a little bit lower down. So how to get the right area to perform the superior trunk block is that you start in the supraclavicular fossa, you get the typical supraclavicular view where you've got the subclavian artery, and then you move the probe slowly up until you get this type of structure, which looks like a chocolate chip cookie, which in fact is the C5 and C6 that have come together before they split into C5 and C6 higher up. It's also important that where you will administer the block is before the suprascapular nerve then separates from here, because when it separates, that's not the right place. It's before it separates from this structure is where you want to give the local, because remember we mentioned that the suprascapular nerve has a 70% cutaneous contribution towards the shoulder, and that's one of the nerves that's very important for you to block for the surgery. For patients coming in for shoulder surgery. Another important thing as well is that look at the level of the superior trunk. It's a very vascular area. You have to be very careful about blood vessels. And here you can see this is a blood vessel. So the common blood vessels that we are mainly concerned about when one is performing superior trunk block, one of them is the transverse cervical artery. So you always have to be aware of where the vessels are, and you want to avoid them when you are advancing your needle towards the structure or a target of interest. Otherwise, generally, this is an easy block to perform, and in literature, patients get we noted about 5% of them, when the block has been performed correctly, about 5% of them may have phrenic nerve palsy. That's a stark difference to more than 70% of patients getting phrenic nerve palsy after an interscalene block. So coming to the conduct of anesthesia, so like with any anesthetic, you have to attach your standard American Society of Anesthesiology monitors. So that's your ECG, your pulse oximetry, non-invasive blood pressure. But in addition to that, you may need an arterial blood pressure, especially in patients who are high risk or frail patients coming in for shoulder surgery. We advise using a depth of anesthesia monitor like a SedLine or a BIS. That will help you to titrate your anesthetic so that you don't give too much or too little. It will be terrible to wake up under anesthesia in the sitting position with the tube in your throat. That's terrible. So it's important to use a depth of anesthesia monitor so that you make sure that the patient is adequately anesthetized. One can also use near-infrared spectroscopy monitor. This will help you to assess the level of cerebral oxygenation. There have been studies that have proven that when patients moved from in a supine position to a sitting position under anesthesia, the cerebral oxygenation does decrease. So using an infrared spectroscopy monitor will be able to help you monitor the cerebral oxygenation. So the evidence for the routine use of near-infrared spectroscopy in shoulder surgery is not yet compelling. However, some studies noted in UpToDate showed that patients who had shoulder surgery and had a drop in the cerebral oxygenation in the sitting position were noted to have some cognitive impairment after 24 hours post-surgery. The non-invasive blood pressure will need to be placed on the same side as the IV because the surgery will be on the opposite limb. So it's advisable to make sure that you have you insert a wide bore cannula so that the fluid can freely run into the patient and you don't have problems injecting your medication. It's also advised to use a clave so that you can attach infusions intra-op, because we often need to run vasopressors when these patients are in the sitting position. As I mentioned, invasive blood pressure monitoring is not always a must, but is advised, especially in high-risk patients. It's important to zero your transducer at the level of the circle of Willis. That's basically at the level of the ear, so that you get the correct blood pressure reading. So in terms of depth of anesthesia, I mentioned the Z line. So you'll attach it while a patient is awake, and then when the patient is asleep, you will be able to track the depth of anesthesia. What I have noted, what really helps is not just looking at the dimensionless number here for the Z line is called the PSI, but actually having an appreciation of the waveforms, looking at the high frequency, low amplitude waveforms while the patient is awake, and seeing the transition that takes place as the patient slowly drifts off to sleep and eventually reaches an adequate plane of anesthesia, and to see how those waves change, and then monitoring the changes also in the waveforms as the patient begins to wake up. I've found that to be extremely helpful in monitoring the depth of anesthesia and predicting the wake-up time. I also pay attention to the density spectral index, spectral array, which is shown at the bottom of the screen. Typically, when the patient begins to wake up, you get this unzipping pattern here, and that begins to tell me to prepare myself, because I know the patient will be waking up anytime. And then I also start looking at to see if the patient is satisfying my extubation criteria, and prepare to extubate the patient, because it can happen very, very quickly, especially in the young patients who come in for shoulder surgery. I find they wake up extremely fast. So it's important to have this monitor at hand so that you are in control, you know what's happening with your patient. On the right is the INVOS, so-called INVOS, which is a near-infrared spectrometry monitor. With that, there's no actual value, which is said to be the value, the normal value. We base this on the baseline. So you attach the monitor, it's more similar to this, but you attach the monitor to the patient's forehead and assess what is the baseline at which the patient is. And basically what you want is to make sure that the patient remains within the normal range, so that they don't have a drop in this value by more than 20%. So we've got L here, which stands for the left hemisphere and the right hemisphere, and the probes are mainly stuck onto the cortical area, so they're mainly in the cortical area. And when there's a drop of 20% or more, you can see the change in color. This signifies that some action needs to be taken. So in this case, because this is cerebral oximetry, one would need to optimize oxygen delivery by making sure that the patient's HB is optimized and supply adequate FiO2, make sure that the patient's blood pressures are, just to give some vasopressor to improve the patient's blood pressures, and in effect to improve the mean arterial pressure, and then that will also lead to an improvement in the cerebral perfusion and ultimately improving your INVOS number. Induction, generally we would administer propofol or any other induction agent that you have, which is not contraindicated, and a short-acting opioid like fentanyl or sulfentanyl, and then administering muscle relaxant as you would for a standard anesthetic. Prophylactic IV antibiotics will be required for shoulder surgery, and surgeons often ask for tranexamic acid. Typically, it's 1 gram of tranexamic acid, which would advise running for about over 10 minutes because it can cause hypotension. As well, it has been noted some patients can actually have a seizure while receiving tranexamic acid. So it's advisable just to give it over 10 minutes as opposed to just bolusing it in over like 30 seconds or 1 minute. Then for maintenance, you can choose whether you're going to go for a total intravenous anesthetic using a specific TCI model or using a volatile anesthetic. So what I've found is much easier at times is to run a volatile anesthetic with a background remifentanil infusion. If the patient has a high risk for post-operative nausea and vomiting, then I will then run a propofol TCI and a remifentanil infusion, and also your vasopressor, so that the blood pressures are maintained within acceptable limits in order to maintain cerebral perfusion. So as I mentioned, generally it's going to be a general anesthetic because some of the cases can be long endotracheal tube, and it's important to secure the tube on the non-operative side and put a bite block in the patient's mouth. So some authors have talked about using a ray tube or a reinforced tube. In my practice, I tend to use just a normal tube, and we just place it on the secure it on the non-operative side so that does not interfere with the surgical field. And yeah, we never really have any major issues. So this is the position that the patient would adopt. So this is the modified B chair position. It's important to note that the patient's head is in this particular device. There are no armrests on this particular one because I think the patient is awake, because this is actually an awake patient. This person was actually demonstrating. It's not an actual patient, but this is a demonstration just to show how the patient would be on the bed. And then in a real patient, the patient's hands will be on arm boards when they're asleep, and also we would place something underneath the knees, make sure that they are relaxed and slightly flexed, to avoid pressure, any pressure points. And the important thing of the hips and the knees is to avoid stretching the sciatic nerve. We also put some padding underneath the ankles to avoid pressure sores. The head must be secured and avoid excessive flexion, which may lead to airway compression, venous congestion, and even airway edema. So this position is associated with complications because it causes physiological changes. When there are physiological changes associated with this position, especially under anesthesia. One of the things that happens is hypotension, and the hypotension is due to vasodilation, which is induced by the anesthetic. So blood tends to pool in the lower limbs. That then leads to a decrease in preload. A decrease in preload means then a decrease in stroke volume. A decrease in stroke volume then translate to a decrease in cardiac output. Decrease in cardiac output will mean a patient is going to have hypoperfusion to the brain, to the heart, and that will be detrimental. So we don't want that to happen. So this is one of the things that happen when a patient is in the sitting position under general anesthesia. Venous embolism can occur, but is not as common as in if the patient was having neurosurgery in the sitting position, like for things like posterior fossa surgery. The risk of venous embolism is much higher there than for shoulder surgery, but it can occur, and one needs to be vigilant during surgery, watch out for that. And typically what happens to this patient is that the EtCO2 drops and the patient begins to decompensate. So it's important to watch for that. And then they also talk of a Millwall murmur, but it's not easy to hear unless you have got experience of it. But it's something that one needs to be aware of. Airway edema, I've mentioned that. Cerebral hypoperfusion can also occur when these patients are in the sitting position because of a drop in mean arterial pressure. The other thing that can also cause cerebral hypoperfusion is if a patient is being hyperventilated. So hyperventilation will lead to hypocapnia. Hypocapnia will lead to cerebral vasoconstriction, which will then lead to cerebral hypoperfusion. Cerebral oxygen desaturation has been noted. I did mention that. So there was a study that they performed, and they applied near-infrared spectroscopy monitors to the patients in the supine position. Once the patients were in the sitting position, it was noted that the cerebral oxygen decreased and by more than 20%. So cerebral oxygen desaturation can occur in the sitting position. Nerve injuries, we talked about the ulnar nerve, which may potentially be injured, in the sciatic nerve, and even the brachial plexus. So one needs to be aware of possible nerve injuries in the sitting position and how to mitigate those. So in the sitting position, paying attention to the hemodynamics. This image is not so clear, but I included it because it's not one that often one comes across. So this is the only one I could get. So what the purpose of this, what this image shows you, is that when a patient is taken from the supine position into the sitting position, there is a difference in height between where the non-invasive blood pressure is and to the level of the circle of Willis. And in this diagram, it's about 20 centimeters. So the difference between the non-invasive blood pressure, which is the middle part of the non-invasive blood pressure cuff, and the circle of Willis, which is basically at the level of the ear, is about 20 centimeters, which translates to a drop in mean arterial pressure of 15 millimeters of mercury. So how do we get that? So 1 centimeter rise, that is from the supine position to the sitting position, and often surgeons want the patients to be at about 20 degrees, equates to 1 centimeter rise is to 0.75 millimeters of mercury drop of the mean arterial pressure from what it is here at the level of the arm, which is the middle part of the non-invasive blood pressure cuff. So in this case, it's a drop of 15 millimeters of mercury. So here we're getting 65 millimeters of mercury. That's showing up on our monitor. So we subtract 15 from that, which is 50 millimeters of mercury. That is the map. So is that adequate? So how do we know it's adequate or inadequate? We go back to our physiology. So we want to have a cerebral perfusion pressure of round about 50 to about 70. So if we can get about 50 to 70 millimeters of mercury, that is generally acceptable. So how do we get the cerebral perfusion pressure? So cerebral perfusion pressure is mean arterial pressure minus the ICP, which is the intracranial pressure, or the CVP, which is the central venous pressure. So generally a ballpark figure for the normal ICP in an adult is about 10 to 15. So if you've got a mean arterial pressure that's 75 minus 10, you're sitting on 60. So that's generally okay. So Up to Date says that in their text on the sitting position in shoulder surgery, they're advised at least to have a mean arterial pressure of 70 in the non-invasive cuff. So any mean arterial pressure above 70, they say it is safe. Less than 70, you're bordering in a dangerous zone. So in my practice, I try to aim for above 75 millimeters of mercury. My sweet spot is like 80. I want to aim for 80 millimeters of mercury. However, you also need to know the patient's underlying condition. So if the patient is hypertensive, we know that hypertensive patients, their autoregulatory curve is shifted to the right. So they will need higher MAPs. So in those patients, I tend to aim for like 85 to about 90 millimeters of mercury in the MAP. So because their blood pressures are a little bit higher, they need higher blood pressures in order to perfuse their brain adequately. And the rule I often use is if the brain is safe, the heart and all the other organs are safe. And that's particular, that relates mainly to shoulder surgery, not in every surgery. But when it comes to shoulder surgery, I always tell myself that if I can push the maps up in order to perfuse the brain well, then my heart is fine and all the other organs are fine. And in principle, that is actually true, because what we aim to perfuse most here is the brain, because the brain is the one that's mainly at the risk of compromise in terms of perfusion. So the other complications, so the complications we talked about how to remedy the issue. So to avoid hypotension, because it's given, and I've seen it many times with shoulder surgery. Once the surgeons ask you to take the patient from the supine position to the sitting position, it's given. The patients vasodilate and they drop their blood pressure. So we already start running vasopressors while they are in the supine position. We start at a low dose of phenylephrine, and once they get into the sitting position, we increase or we crank up the dose on the infusion pump so that we can be able to maintain the patient's mean arterial pressures. And in order to prevent hypotension, you need to make sure that your patient is adequately hydrated. So you want them to be euvolemic. Patients may come to surgery dehydrated, so it's important to make sure that prior to administering the anesthetic, you start giving fluids so that your patient is fluid replete before you administer any anesthetics. Because if the patient becomes hypotensive in the supine position, I definitely guarantee you that once you get them into the sitting position, the blood pressures will crash even much further. Venous embolism, as I mentioned, is rare, but should it happen, you want to put the patient to the Durance position. So you announce to the surgeons to stop everything that they're doing. So if the patient is in a sitting position, you put them into the supine position and then turn them into the left lateral position, head down. That's the so-called Durance maneuver. If that's not working, because the aim of that is to kind of prevent the airlock that might occur because of air that has been entrained into the venous system. If that doesn't work, chest compressions can also dislodge that airlock. Airway edema, as I mentioned, are due to excessive neck flexion can occur. Cerebral hyperperfusion, I did mention that, especially if you hyperventilating the patient can develop significant cerebral hyperperfusion. Oxygen desaturation, we talked about optimizing oxygen delivery, I did, and we talked about padding to prevent pressure sores and nerve injuries. So patients can also come in for shoulder surgery, and some surgeons perform the surgery in the lateral position. With the lateral position, you don't have to be as aggressive when it comes to the blood pressures, because the patient is more or less in a similar position as the supine position, in that the heart, the lungs, and the brain are more or less at the same level. So you would manage this patient as you would for every other patient who is in the supine position. In terms of hemodynamics, there is no true need to infuse a vasopressor in the background for these patients. So you would just make sure that they're hemodynamically stable and their pressure points are protected. So you need to make sure that the patient's head is in a neutral position. You want to avoid excessive hyperextension. You want to avoid hyperextension of the neck. That may potentially cause a brachial plexus injury. Then you want to put an axillary roll. Just important to note that the axillary roll is not actually placed in the axilla. It's actually placed distal to the axilla. It's more like in the region just where the start of the rib cage is, and not in the axilla, because if you put it in the axilla, you're going to cause a brachial plexus injury. So the aim of this is just to make sure that the patient does not develop any pressure ulcers. And then they also attach a beanbag and also some padding between the knees so that the patient does not develop pressure sores. In terms of ventilation, you do know that this patient now is in the lateral position, so you now have a dependent lung and a non-dependent lung, and that might be that it depends also on how the patient's baseline pulmonary mechanics and also if they've got any lung disease. So what will happen is that when the patient is in this position, the dependent lung will be with the one that's kind of more ventilated and more oxygenated. But in a general healthy patient, this shouldn't be much of an issue. It normally becomes a big issue if we are involved in thoracic surgery where the chest needs to be open. But it's just an important thing to note that in this position, you have a dependent lung and a non-dependent lung when you are ventilating this patient. And if one of the lungs are diseased, you just need to think about what is going on, because you might have a situation where the sats begin to drop, and you now need to think to yourself, okay, which of the lungs are diseased? Is it the dependent lung or the non-dependent lung? And what strategies you probably need to perform in order to make sure that the patient is ventilating adequately. Right. Other complications is vascular injury that can occur due to severe hemorrhage. Sometimes these things can happen, and it's always important to have situational awareness and not just be locked in your anesthetic cupboard, looking at the beautiful, infographics and looking at, the tracings on your machine and being dazzled by that. You need to actually have situational awareness, look at what the surgeons are doing, look at what's happening in the surgical field, and look at your patient. Sometimes we actually, as anesthetists, we just look at the numbers. We look at the screen, and we forget about the patient, and we think, oh, if the numbers are fine, the patient is fine. So it's also good to look at the patient, what is actually happening to the patient at the time, because bleeding in this type of surgeries can be occult, and when the patient decompensates, they would have lost a significant amount of blood. I know this from experience, because I have had 2 instances where orthopedic surgeons have caused vascular injury in patients having upper limb surgery, and the vascular injuries was significant that they needed to call a vascular surgeon to intervene in order to save the patient's life. So you need to be aware of those things. Another thing that might also occur is having a swollen uvula. So it has been documented in shoulder surgery, and the main issues, or the main things that are main contributors, or the things that have been implicated in swollen uvulas, is excessive suctioning. So at the end, you should avoid excessively suctioning the patient. If you need to suction under vision. And also, if you need to perform laryngoscopy, it's advisable to use a video laryngoscope so you avoid trauma to the airway and increase your chances of first pass success. Another thing that might also contribute to the uvular swelling is the endotracheal tube. So because in shoulder surgery, the surgeons will be pulling on the shoulder, it might cause the endotracheal tube to move from side to side. And as it moves from side to side, it may actually scrape on the uvula from side to side, and in that way traumatize the uvula, and the uvula can become inflamed. We'll talk a little bit about how to manage that in the next slide. And then cerebral ischemia can also occur, and I did mention that there were studies that showed that post-op these patients develop cognitive impairment after shoulder surgery. So the uvular swelling, as we mentioned, can occur in some patients, and according to Zamir, he graded these to grade 1 to 4, and this is the grading system. So what the article by Zamir et al. Advised is to examine, when you do your Mallampati, to also examine the uvula and document the size of the uvula prior to surgery, and to note if there's an increase, if it's a large uvula or not, so that if there's any issue post-surgery, you can be able to actually you'll be able to use your initial physical exam as a reference point. So with grade 1, there's an increase in size, there's a translucent and shiny appearance with increased turgor. With grade 2, you get an erythematous uvula with visible hemorrhages and ecchymosis. Grade 3, you get clearly demarcated red-white colored necrotic slough. With a grade 4, you get auto amputation of a necrotic uvula. So if a patient develops a swollen uvula post-op, the important thing is to ask yourself if the patient is at a risk of airway compromise. So if they're having problems with breathing, they need to be sent to an ENT surgeon for an intervention, because if you send them home with a swollen uvula, the airway is going to be compromised. If the patient's uvula is not swollen to the extent that have issues with breathing, you would advise them to continue monitoring themselves. If they feel like the swelling is increasing, then they need to go to the ED or the emergency room as soon as possible. To reduce the further swelling of the uvula, what can you do? So the first thing is to administer anti-inflammatories if they are not contraindicated. That will reduce the swelling. Dexamethasone also can reduce the swelling. It's a corticosteroid. Another thing that has been noted in literature is taking ice chips. So if the patients can take ice chips, that will reduce the swelling as well. And gargling. So gargling with antiseptic is important because it reduces the chances of them getting severe inflammation, which then might lead to a necrotic uvula, an infected and necrotic uvula, because that's not where that will be highly undesirable. So the interventions are aimed to mitigate swelling of the uvula, further swelling of the uvula, and also to pave way for a faster recovery and prevent the development of a necrotic uvula. So emergence, you aim for a smooth emergence. So with these patients who've had shoulder surgery, you don't want them to wake up fighting and bucking, because in that position they can potentially injure themselves. If a patient has got a C-spine pathology, if they start coughing in this sitting position and becoming restless, those types of movements can actually exacerbate their C-spine injury. So you want to be careful with those patients. The best thing I always advise is not to extubate the patients in the sitting position inside while their heads are in that type of harness device, because number one, it's uncomfortable for the patient. Secondly, it's difficult for you to manage the airway. If you need to manage the airway in a restless patient that is sitting up, it's very difficult to mass ventilate the patient in that position. So the best thing is to put them into the supine position so that you have control of what's happening with the patient, and you have better control of managing that airway should an airway emergency arise. So in order to ensure a smooth emergence, I'd advise using a depth of anesthesia monitor. So this is what I do. Use a depth of anesthesia monitor like a SedLine or a BIS, paying attention, as I said, to the waveforms, paying attention to DSA, which is digital spectral array, to look for signs that the patient is beginning to wake up. So what I would do is, because sometimes the surgeons want the patients to wake up very quickly, because most of these ORs are very fast turnover ORs. So while the surgeons are beginning to suture the skin, I completely switch off the volatile and I monitor my depth of anesthesia monitor, look at my depth of anesthesia monitor to see how the patient's depth of anesthesia and how the patient is beginning to slowly wake up. Completely switch off the volatile. If I'm using volatile, if I'm using TCI pump, I then look at the patient's decrement time, and based upon the decrement time, I will then decide what to dial up into the TCI pump or to stop it completely. And I make sure that I time my wake up to what the surgeons are doing, because normally with these shoulder surgeries, initially they have to like close up the tissues inside and they kind of close them in layers. Then the next thing, they'll be onto the skin. From the skin they move very quickly. They then have to, sometimes they might put in some clips, then they will put in a sling. So that, depending on how quick the surgeon is, normally that takes about 15 minutes. So if you are using a TCI pump, then you will be aiming for a wake up time. Your pump can give you the estimated wake up time. So you aim for a wake up time of about 20 minutes, then you switch off your TCI propofol pump. If you're using volatiles, what I would advise is just to stop your volatiles, but keep the patient on a low flow so that you don't flush out all the volatile and then have an awake patient in the sitting position, that will be undesirable. In addition to that, we run a very low dose of remifentanil so that you have what we call it a REMI wake up. So that helps because it helps the patient tolerate the tube and avoids the patient barking and coughing, and they wake up much calmer. It's very helpful in the younger population, especially young patients we've seen who are roundabout in their 20s and 30s. We've noted sometimes when they wake up, they can be a little bit difficult and disorientated. So doing a REMI, what we call a REMI wake up, really helps to facilitate a smooth emergence, and it just makes the whole patient experience way better. And as an anesthetist, it just makes you to look so much better, because it gives everybody in the operating room that you are in control. Sorry about the spelling mistake. It should be emergence, and I missed their remifentanil wake up. All right, so the patient, you want to extubate in a supine position. You want to avoid excessive suctioning, as we mentioned, because you don't want to have the swollen uvula. So don't over-suction, don't be overzealous. Remember also that your patient has been in the sitting position. So in the sitting position, remember that in a sitting position, in a patient who has good hemodynamics, that is actually an optimal position because the diaphragm, you've got good chest excursion, you don't have abdominal contents pushing up the diaphragm, so the patient actually breathes much better, and their chances of having atelectasis is much lower because they are in that sitting position. So pulmonary mechanics are much better. In fact, what I often advise is actually before you put the patient in the sitting position is to recruit the lungs while they are in that sitting position, so that you recruit as many alveoli as possible, so that once you put them into the sitting position, the patient doesn't suffer from atelectasis. And always be vigilant when the patient is waking up, so that so that the patient doesn't pull out lines. You make sure that the patient is safe. What we often also do is take off that harness that they have, so that when they wake up, they're not pulling on it and there's no tension on the neck. So the patient is completely free and you can easily access the airway if you need to. Post-operatively, we advise administering supplemental oxygen because the patient has had a block, and the block does cause phrenic nerve palsy. So you want to have the patient on oxygen post-op. Even if the sats are normal at the time of extubation, they will need some sort of supplemental oxygen. Even also going into the recovery, they'll need some oxygen, and you need to give an instruction to the recovery nurses that they should keep the patient on oxygen until the patient is fully recovered, breathing well on their own and able to cough. So that's very important. Make sure that the operated limb is in an arm sling. With shoulder surgery, the surgeons are often diligent at putting the patients in arm sling, but sometimes in some surgeries, it's important that you be proactive, because remember, if you've administered a block to that particular limb, the patient cannot feel that limb, and they can easily move it and injure themselves without feeling anything. So it's important that that arm be in a sling. Counsel the patient about numbness. Often if they've had an interscalene block, the numbness may last even up to 24 hours, especially if you've added adjuvants like adrenaline or epinephrine or dexamethasone. The block duration will be prolonged. So the patient might be worried, like, why is my hand still numb? Why is my hand still weak? You just need to reassure them, tell them that it's going to be numb, it's going to be weak for about a few hours or even up to a day. So that they know exactly what's going on and they don't panic. You need to make a follow-up call just to find out how they're doing and whether the block is beginning to wear off. It's also important to draw up a clear plan, especially if you're doing ambulatory surgery where you've got patients going home on the same day. You need to create or discuss an analgesic plan. And what we often advise our patients is that when they leave the hospital and they get home, they should start taking their oral pain meds. Even if they don't have pain, they need to start taking their oral pain meds. They can start with paracetamol, otherwise known as Tylenol, which is acetaminophen. They can start taking that, just a small dose. This is so that when the block wears off, they get some analgesic cover and there's adequate overlap between the oral meds, because the oral meds take time. I always explain to the patients that the oral meds take time to kick in. Why? Because you take them orally, they need to be absorbed through the gut, and medications like acetaminophen undergo hepatic metabolism, so the so-called second pass effect. So these medications take time to actually start kicking in, and so it's better to start taking them in advance. And most of the patients that do that have a good experience. It also is an important time as well to empower the patient to take control of their pain management. I found that patients really like that. If they don't have a lot of pain, they will opt not to take the opioids if in that period, but they'll take something like Tylenol or an NSAID if it's not contraindicated. But as the pain begins to get worse, then they can introduce some opioids sparingly. But generally with the block, we find the patients do quite well for the first 24 to 48 hours. And if they're taking their oral meds, some of them really cope very well. So that's discussing the analgesic plan, and be very clear that the patient knows about that. And to make sure that you can reach out to the patient, or they can reach out to you if they feel that there is a complication associated with the block, so that they can be able to be helped as early as possible. So in conclusion, administering safe anesthesia for shoulder surgery requires good communication between the anesthetic and surgical teams. Furthermore, situational awareness in the intraoperative period is paramount. Patient positioning may be challenging, especially with obese patients. And it's also important to note that patients with comorbidities like hypertensive patients, patients with a history of coronary artery disease, patients with things like pacemakers, you will definitely need to have an invasive monitoring in the form of an arterial line for these patients, because the high-risk patients need to be able to maintain and monitor their blood pressures on a beat-to-beat basis, so that you can act quickly in order to mitigate complications associated with having them in the sitting position under general anesthesia for shoulder surgery. So managing and anticipating complications related to patient positioning is a cornerstone of safe anesthesia in shoulder surgery. Good pain management can go a long way to improving the quality of recovery and preventing chronic pain syndrome. So it's important to have a multimodal approach in terms of analgesia in these patients, because shoulder surgery can really be painful. So, and having different types of blocks in your block armamentarium is very helpful. Attending regional anesthesia workshops so that you are aware of how to perform brachial plexus blocks with proficiency and in a safe manner is important, and that will go a long way to improving your patient pain experience and overall anesthetic experience. Thank you so much for listening to me, and if you've got any questions or comments, please pop them in the comment box. We want to hear what you have to say about this. If you've done shoulder surgeries and your experiences, let's talk about it in the comment section. If there's anything that you're unclear of, please leave us a note in the comment section. And thank you so much for being a part of our channel that's continuously growing, and we are getting more and more students and more doctors. We're getting interested in our network. Thank you so much for listening to all our videos, and please do share our lectures because we want to reach more people. We want patients to be safer. We want people to administer safer anesthetics. And we are so happy that people part of this network are succeeding. They're achieving great things, and they're doing so much for their communities and for their families through this channel. Till next time, thank you, and please subscribe. Bye.